Go for it. Hey, tree huggers!
Welcome back.
Today we have something very exciting for you. We are going to be interviewing Dr. Karen O'Rourke. She's a dentist who specializes in orthotropics, and she's going to be talking with us today about some of the changes that we're seeing within the structure of the faces and the airway and breathing and how that's impacting our children.
Right. We hope to interview her so you could meet Karen because we refer to her often. We wanted you to see her face and maybe ask some questions that you might have. So enjoy Karen.
Wonderful. Welcome. This is Dr. Karen O'Rourke.
Greetings.
Greetings from someplace sunny.
Yes, someplace sunny and warm, but we won't talk about that.
Especially not today in Michigan.
Right.
We welcome you, Dr. O'Rourke, to talk a little bit about your practice today and the things that you're seeing that parents should be looking for, and how ways that you can help. And we want to talk a little bit about tongue tie and your procedures. So a basic overview of your practice and where you've come from and where you see us going, what direction together as a team.
Okay.
So sounds like a lot to cover, but you can get started and we'll just have our general conversation.
Okay. Well, I would just like to say what brought us ladies together as I talk to the audience is that we all care deeply about kids. And, you know, kids are 25% of our population, but they are 100% of our future. And I am seeing a decline in kids as they come into my practice over the 30 years that I've been in practice. And I know my conversations with Stacy and Terry, they can reflect the same. They've been around kids long enough to see that they're not going in the direction that we would hope. And I think parents recognize that something is wrong. And so we're going to talk a little bit about what we see, what they see, and try to give you some guidance as parents for what to look for and what might help your child grow better.
Okay. And so what kind of, when you say a decline in kids, what kind of referrals are you getting?
Mm-hmm.
So we were trained to look at teeth. So I would start my conversation by saying 90% of the kids that walk into my practice have crowded teeth. I am seeing more behavior issues on the kids that as they're in my chair, or they're bouncing out of the chair. I am seeing more postural issues. They're slumping and slouching in the chair. They're extending their heads forward. So just things have changed in the 30 years. I might regress a little bit by saying when I got out of dental school, I did a hospital residency, a general practice residency. So I worked with the oral surgery department for a month and the emergency room and did physicals and worked with cancer patients. And it really kind of laid the groundwork for looking at the whole body and what's affecting it, and not just the teeth. I see in the 30 years that I've been practicing that medicine has gotten very segmented and there's a specialist for every piece of the body, but there's very few people that look at the whole body. And, you know, I give credit to chiropractors who are looking at the whole picture. They're seeing some of the things that we're seeing, some of the things that Terry as an occupational therapist is looking at the whole body and seeing. So I think that as well as looking at teeth and talking about teeth today, I want to talk about what I'm seeing in the faces of these kids, because I think parents will understand that some of these things aren't normal.
Okay.
So when I am looking at a child, if they have a gummy smile where you can see gum tissue below their lips, that's not normal. that's not just a type of development.
And what is
That's,
that a sign of to you?
it's a sign to me that they're growing downwards and backwards instead of forwards. Okay. Now, to re-step, how should we grow? Well, our tongue should be in the roof of our mouth, and the teeth should then drop in around the tongue. We should have our mouth closed and be breathing through our nose. If that mechanism goes awry, and it can go awry very early, then the mouth, if they're not breathing through the nose, the mouth drops open, the tongue drops away from the palate, and the teeth drop down and they drop back in closer to the throat, okay? Which causes them to crowd, which causes the tongue to be driven into the throat, and which can cause airway problems.
And that's interesting just from the whole body perspective and how we think of the tongue as being one of our main balancers and the jaw to link with our head writing and our posture, and then with what Stacy's seeing with regard to language and articulation. And
right. Because it's interesting to me as a speech pathologist, I don't think I was trained to understand that tongue posture and tongue positioning early on, how that would affect airway development. And of course, if the airway is affected, everything I do is affected. Speech development, safe swallow, safe feeding, it all begins with the airway. So
yes,
and regulation.
We weren't trained this way either. You know, when we were taught about crooked teeth, it was implied that it was dad's big teeth and mom's small jaw, and okay, let's move on to see how we can fix them. There wasn't a question of why. And we know now that air is the most important thing that we need. It's more important than food, it's more important than water. Okay, you can go without food for up to a month. People in Reader's Digest articles that are lost in the mountains survive for a month. You can go without water for a week, but you can't go without air for more than 4 minutes. Okay. And how we get that air is also very important. When you breathe through your nose, it warms the air, it cleans the air before it hits the tonsils in the throat, and it also, going through a narrower tube than the mouth, drives the air deeper into our lungs, so that you're getting 20% better oxygenation when you're taking it in through the nose. So we're seeing that the whole head complex is connected, that when that breathing mechanism isn't proceeding correctly, then the teeth crowd. The teeth are caught between an envelope of muscles, the tongue on the inside and the muscles on the outside. And if that isn't in balance, then the teeth are what suffers, okay? So how do we know that this is true, okay? There was a study done by Harvold on rhesus monkeys where they took silicone plugs and put them in the nose. So the monkeys had to breathe through their mouth. All the monkeys within 6 months developed different facial features, breathing through their mouth. Their teeth started to crowd, their faces elongated. He then took those plugs out and the monkeys returned to normal breathing, but their teeth did not self-correct.
okay.
So this is why dentistry plays a role in trying to not reestablish that proper breathing. You also need to reestablish the proper placement of the teeth.
And what I think is fascinating, Karen, about what you're saying is there are so many things that we can see that's indicative of a problem that we can't see. There's just so many indicators on the face and through the teeth that we don't really think of as a symptom of something else, or like this is a symptom of a breathing problem. I really like that symbolism you said of having the teeth be inside an envelope of muscle, tissue on the outside and the tongue on the inside as that force. Because if that envelope is out of balance and you see those crowded teeth, basically what you're saying is that's an indicator of poor airway health or poor airway development, which I think is is huge, that parents need to know what these outside indicators are actually saying.
And we mentioned the gummy smile and the crowded teeth. What are
Mhm.
some of the other outward physical signs that you're seeing that indicate there might be this challenge?
Um, what I've picked up in photos, because we photograph children a lot, is a pale face. Okay. I see after we've gone and corrected the breathing and corrected the teeth, how their oxygenation is better. And it being in Michigan, I have one little example that I show, because the child was photographed in the beginning, and then he was photographed in December, and his color in December is greatly different than that. You can see a downturn to the eyes. The maxilla is this upper part of the face, and it should be growing forward. And you see in babies how they have cheeks that are puffy, and the cheek line parallels the nose. In a face that's growing downward, that drops, and you get a flat face, you get a retruded jaw. Those are all things that you can pick up, that a parent can pick up if you start looking. And I give a lot of credit to John Mew, because when I joined the first practice that I came to, there was a group of dentists here in Grand Rapids that were bringing John Mew over from England. And John developed the technique of orthotropics that we use to treat children. But he is the one that spent so much time with us, teaching us to read the face and learn to identify which muscles were the problems. Because if you know what is causing the problem, you're better able to correct it.
Right.
And I think that's a huge key piece why at Family Tree, we are very excited to continue partnering and working with you, because as OTs, we can only do so much with regard to the vision, the postural system, the sensory systems, and speech can do so much. And there is this huge component that your services and your like-minded clinicians can offer.
Well, the thing is vice versa, because we, are trained to treat the teeth, and it's a huge effort to do that, and to try to retrain posture and give exercises, and we can't do it all. We have to do it as a team. That has to be your responsibility to help us get this child on board, training those habits that have gone wrong.
Sure. And that's what we like to do.
Exactly.
Yeah.
Absolutely.
So as OTs, in on our podcast, we've talked about various things that can be influencing posture and the lack of tummy time and some of these early experiences. From your experience, what are some of the things that are causing that open mouth posture or more mouth breathing that you're seeing?
Well, I think there are a lot of things that play into it. But I think that it's critically important that we nurse our babies. And there has been a lot of emphasis on the quality of the milk, and that's why we should nurse. But nursing our babies drives the mechanisms that establish normalcy. You're pumping that nipple between the tongue and the palate, and it's forcing pressure on the palate to develop out. And the palate is the roof of the mouth, is the floor of the nose. So it's broadening that nasal form and allowing that air to travel better. It's a child cannot nurse and mouth breathe at the same time. So they're becoming obligate nasal breathers as they nurse. And so I think the whole mechanism, as God planned it, is how it has to happen. And so what's gone wrong? Well, we don't nurse our children as generally across the board as we used to. We certainly don't do it for 2 years, which is what our ancestors used to do. They used to solely nurse for 2 years. And then when they introduced foods, once the teeth were in place, they were hard foods. They weren't cooked. They were nuts and grains, and they had to use their muscles. Well, children are not using their muscles now. probably only 10% of what our ancestors were. So they're going from nursing to a bottle to mushy food, and they're not using these muscles. And so they're becoming more slack and dropping their mouth open. They're developing allergies because they're inside. There's a lot of dust mites, etc. So it can be habit. It can be implemented by what's happening around that child. But, the Native Indians, moms used to, when they saw their childs with their mouth open, used to pinch their lips closed. They recognize the importance of that. And I would say, if nothing else, we need to get our kids breathing through their nose.
Mm-hmm. Speaking about using bottles and such, what is your stance on kids using pacifiers or other things, other artificial things in their mouth?
Well, as I said, the tongue needs to be up in the palate for normal development. And anything that's going to interfere with the tongue being in the palate is a problem. So to me, ideally, you wouldn't even introduce a pacifier. But if there are grumbly tummies or issues with that newborn, perhaps use the pacifier. I would say no more than 3 months. Typically that child's going to work out of any issues that they have. But we don't want it in there because it's interfering with that tongue to palate. A bottle, a sippy cup that has a lip is that same idea. It's interfering with the tongue to palate and not allowing the proper swallow to develop. So they have inverted sippy cups. And now we're talking, prevention for you parents,
Right.
to look at some of those tools.
Okay, good. Do you have other suggestions, anything you can think of that you would tell a parent? Like, what would you tell a parent who's either having a baby or has a newborn? What would be like a few suggestions, a few hot tips?
Well, I'd love to get the parent before they have the baby.
Oh, okay.
Okay.
Because a lot of dentists do 1 year, they suggest, right? Or 1 year kind of to establish
visit.
general care.
Yes.
So
Yes.
ideally, I would love it too if pregnant women came to see their dentist while they were pregnant. So do you have that happen? Do you have women come to you early?
Only the patients that come to us that we know are expecting. We have an expectant parent package and we talk to them.
You do.
But there are a lot of, we've danced around the idea of airway, and a parent's airway is very important in the development of their child. And so, parents should be breathing through their nose. They should be, if they're snoring, if they're tired, they should be checked for apnea, because as a mom carrying that baby, or as a dad, with the seed for that baby, that can all be affected. And we have a lot of Asperger's and things that show up when a child is born. And I, don't have the expertise to say it's due to that, but I have an intuition that certainly the parent's airway can play into the development of the child. Probably a topic for someone else or another time. But
But interesting to think about them learning their own breathing habits, even from the standpoint of teaching those things to their child or seeing them as being important, or just monitoring that their child is breathing through their nose. Because I know where we are when we ask the question, does your child breathe through their mouth? It's no right away, because I think there's a preconceived notion as to what that looks like, or they think that your mouth has to be wide open to be breathing. They don't think of it as, like you've been saying, it's anytime the tongue is disrupted from hitting the palate. So when we talk about it, we're kind of careful, or we ask for videos at home while they're sleeping. We're careful with our words because we say it can be even just a little bit agape, but any mouth posture that keeps the tongue away from the palate is what we're talking about. So I think those parents maybe who work on their breathing beforehand, they would at least be more aware of that too. That would be great. Okay.
But
So
yes, for expectant parents, definitely the things that we touched on, avoid pacifier use, do everything you can to nurse your child. You touched on tongue ties, lip ties. Those can be reasons that a mom has difficulty nursing, a tongue tie or a lip tie, so those should be checked right away. They should be dealt with as soon as they're diagnosed. And sometimes that happens right away, and sometimes it doesn't happen until a child is 5 or a child is 12. But again, if a tongue tie is where the tissue is binding the tongue or the lip down, and if you can't get that tongue to the palate properly, then development isn't going to happen properly. It may or may not affect speech, may or may not affect nursing, but has to be looked for and dealt with.
Sure. What were you going to say?
I was going to ask, who do you think is the most qualified to really dive in and look for a tongue tie? Would you say in general PCPs are pretty good about that, or we want to look towards someone like your office or pediatric dentists who really specialize in that?
You know, it's really tough. When babies were delivered in the 50s, it was looked at and dealt with right there at the delivery. And midwives used to keep a hooked nail, and they would release the tongue tie with a hooked nail.
Oh, wow.
But they have gotten away from training OBs, doctors, PCPs to look for it. So ideally, yes, they should be trained, but if they're not, certainly a dentist of any type, be it a pediatric dentist, a general dentist, can certainly look and diagnose it. And if they don't treat it, then they can direct you to someone who can treat it.
Right. Now, do
Certainly.
you always suggest, usually you refer to our office for what's called myofunctional exercises, correct, in an older population? And even in the younger kids, suggest nursing right away and feeding as a way to carry that over. Because I know sometimes we get referrals of people who have had tongue tie revision, but then they didn't have the follow-up. So how important is that follow-up or even the pre-work leading up to the tongue tie? Really?
It's critical to the success of the treatment. And honestly, you shouldn't be doing the treatment if you're not doing the stretches. Our mouth has a great ability to heal up and heal over. And you've all experienced that from extractions, wisdom teeth, within a week, that area kind of heals over. Well, it's the same with the tongue tie or lip tie release. It's going to heal over and sort of reattach if you don't do stretches that keep it open. So any infants that are done, we suggest stretches every 4 hours for 2 weeks, but not waking the baby up. So as soon as the child wakes up, you go in the shape of a cross, up and down 3 times, up and over, firmly on that tissue. And we demonstrate it in the parent's mouth, tongue, and lip. For an older child, yes, the stretches are important, but then there's also that reprogramming where you come in, where you're retraining them to get that tongue up in the palate now that they have the freedom to do that, because just releasing it isn't going to guarantee that the tongue is going to get up there.
And I think that's one of the most important things that we try to get across. Like Stacy had mentioned, the pre-work, and that pre-work is not just in the mouth, it's within the whole body as well, because there's that entire fascial system that connects that frenulum all the way down to our toes. And so there's whole body components and things that we can do, and we want to get that tissue as elastic as possible, so when it is treated, that it has the greatest range of motion and flexibility possible. So
right. I think most of the adults that I've seen post tongue tie, their biggest kind of wow moment is that their neck and everything feels so like they didn't realize the tension they were carrying in their posture, in their neck and their back. They didn't realize how many compensations they'd made through the years for that tissue being tethered there, and how it had really affected their whole body. It's rather shocking. So that's why when we see it in the little ones, we refer to you right away for evaluation. And of course we begin pre-treatments, whether you would suggest it being released or not, because we still need to, work on that elasticity and movement and the swallow. So we find you to be very pivotal, Karen. So tell us, do you want to add anything else about tethered oral tissue? Because I have another important question I want to ask you.
No, go ahead.
Okay. So in your treatment, what is your treatment? What is your office when someone comes to you and let's say we see some of this facial growth, some of these indicators, and then they come to you. Number one, what does a consult look like with you? What do you go over with the parent? What do you measure? And then what is your treatment approach?
Well, we are looking at uh, facial indicators, muscle indicators, and teeth indicators. So typically an appointment is an hour with us. A good half hour of that taking measurements. We measure, is the cheek line parallel to the nose? Is it off by 10 degrees, 20 degrees, 30 degrees? Are the eyes downturned? Can you see the white of the eye underneath? So we're looking at the face. Is the face flat? Is the jaw retruded? Then we're looking at the teeth and we're taking measurements for how much backward growth has occurred by measuring what we call an indicator line. Looking for cross bites, open bites, discrepancies in the teeth. And then we look at how the child swallows, looking for tongue position, and again, which muscles are working overworking in comparison to the other muscles. So then we can try to have that addressed. And typically when we involve a therapist, we either involve a therapist at the beginning before we start, or more likely at the end of treatment when the child is out of the appliances, at least during the daytime. Because when we expand the upper jaw, we have a big block of plastic that holds a screw in the appliance, so they can't get their tongue to the palate as we would like. That appliance has to take the place of the tongue in order to get that expansion. Once we get it and hold it for a period of time, then we can start backing off. And it's at that point when we can introduce therapy where you can help that child get their tongue up into the roof of the mouth. But at least we've created an environment for them.
Okay. And what is that device called that you utilize?
So the treatment that we do is called orthotropics.
Okay.
Orthotropics means to guide growth. Orthodontics means to straighten teeth. So typically orthodontics has been introduced later in life for the child. Back when I was trained in school, it was done on when all the permanent teeth were in place at the age of 12 or so. Well, what I know about growth and development now is that a child reaches 70% of their head and neck development by the age of 5. By the age of 12, they're virtually fully developed. So you can align teeth at 12, but if it's in an improperly growing face, then you're not correcting all of the problem. Okay. And when Dr. Mew introduced orthotropics, his ideal was to treat around the age of 8 when a child had a growth spurt. But the longer that we've been in treatment and the more we know about growth and development, to me, we should treat as soon as the problem is recognized, as soon as the child can be treated. Like I said, introducing anything that will close the mouth, the myomunchie, any tool that we can give, and then starting expansion as early as 3.5. And just trying to normalize that child for their age and stage. I think that's what they do in medicine, and somehow we got away from doing that in dentistry. And looking for the easiest way to straighten the teeth when everything was there. As a result, this treatment can take a longer period of time working with the growing child. But it's non-surgical, it's non-extraction. So what the treatment involves is expanding the upper jaw. And I described that the face was dropping down and back, and that's why the cheeks were flattening. Well, if things have dropped down and back, we have to take them forward and up. What that does is creates, your teeth should look like this. It creates a discrepancy, and that scares a lot of parents. It scares a lot of dentists. but we're taking them back to where they should be and then growing the lower jaw forward to meet them, so that we're getting things back to where they should be and not letting everything come back and then trying to shuffle them around back here. Because then you have to pull teeth, or you don't have room for the tongue and the recrowding occurs. There was a study done by an orthodontist by the name of Little, and 10 years out of orthodontic treatment, 90% of the patients treated were dissatisfied with the recrowding that they experienced. Well, why is that? Was it poor treatment, or weren't we looking at the causes?
Sure, right.
Addressing the causes.
Absolutely. Now, I know a question a lot of parents ask me, because you said treatment can start as young as 3.5. So is that managed by a 3.5-year-old? Is there pain involved? Like, how does a mom or a dad manage that when they think, wow, that's really young to introduce something into their mouth? And how are we going to handle it? And how's the kiddo going to handle it? So what thoughts do you have on that? Or what do you tell your parents?
Parents have become more protective over the years that I've been in dentistry, and they don't want their child hurt. We don't want to hurt children.
I know you don't, Karen.
But truly, we want to set that child on the road to health.
Yeah.
And it is amazing to me how well kids do. They adapt so well.
They're so resilient. I think
incredible.
that too. Yeah.
You know, I haven't had, I can think of one failure where the child didn't make it through the impressions. Whether it was the child's fault or the mom's fault, I'm not sure. But these 3.5-year-olds, I remember I had a set of twins, 3.5, and got the impressions fine on the one. On the other one, I went to take the wax bite first, and he couldn't even tolerate the wax in his mouth on his tongue. So we managed to get the bite. We got a very quick setting material, and we got that impression. And once that appliance went in his mouth, he just really, the first 3 days are very difficult as they learn to manage it and learn to eat with it. It's not that it hurts them, it's just very different and takes up room, and it's hard to eat. By the end of 3 days, they are off and running, and it's like there's nothing in there. And certainly some kids do better than others. Some are slower to adapt than others, but they do remarkably well, really.
Yeah. I think that's usually the advice I give as well. We have a therapist. I'm sure she won't mind us mentioning her, because we're going to do a podcast with her. She's thrilled. By the way, it's Jessica with her little one.
Good.
And she's doing amazing. And and she just needed a little boost in the beginning. She was a little nervous, and I told her about the long-term goals and what we were going to do. And she was like, all right, I'm just going to do this. I'm not going to get stuck on it. And she didn't, and her daughter did great. So,
and she also really loved the fact that you called it mouth jewelry.
Mouth jewelry. So good.
Very good. That was very helpful for this little
It
girl.
might be better for the girls than the boys. For the boys, it's kind of like a football mouth guard.
There you go. Something, but that was good. That was good. Okay, great. So about how long does the treatment last? I'm sure everybody's different, but is there a range of how long it takes?
Well, there certainly is. When we're talking about these little ones, 3 to 5 years old, it's a short spurt of treatment, about 6 months, where we're expanding them, and then we have to let it sit for a while, let them wear them for probably another 6 months, and then dial down to nighttime only. So the appointments coming back and forth are every 3 weeks or so, while we're the parent is turning a screw in the appliance. And let me say that there are different rates that you can expand, and generally in orthodontics, it's rapid palatal expansion, that's the term. But Dr. Mew established a semi-rapid rate of expansion. So it's 1 millimeter a week. So a millimeter is very small, and we're doing 1/8 of a millimeter turn. So the child doesn't really feel, the appliance might feel a little tighter. They don't really feel a difference when they do that turn. So the parent and child are coming in every 3 weeks, probably for 6 months. It takes longer to expand the lower jaw because the bone is more dense. So we have to go at half the rate that we do on the top. So the top gets completed, we continue with the lower, and then everything is held for a period of time. So active treatment is 6 months, and then they don't come in for appointments, only come in if it loosens or there's an issue, and that child is done. You know, we correct cross bites, we get expansion, we get things unraveled. Just for a parent's sake, at the age of 4, a child should have space between their teeth. They say you should be able to fit a nickel between each of the front teeth. Okay, that's about 2 millimeters. Why is that? That's because the permanent teeth coming in at the age of 6 or so are twice the size of the permanent teeth. So a parent will look at their child and all the teeth are aligned and straight, and they say, hey, we're doing good.
Right.
Dr. O'Rourke saying, hey, we're not doing so good. We need to be seeing space now, or we're going to see problems later.
Okay.
And why not unravel that space before the teeth come in so that they drop into place correctly?
Yeah, yeah, definitely. Okay.
I heard one orthodontist speak, and she said the teeth should stand out proudly. And one of those pictures I sent you shows how the teeth are spaced and standing upright. So many kids, their teeth are all rolled in. You know, those muscles just take everything right in so that they're not even standing straight on the bone. They're all rolled in and they're all crowded. That's a clue that things are not going in the direction that they should.
Great. This is great information, Karen.
I'm sure we could talk to you for hours.
Oh, hours. Is there
Probably
anything else? I know
Probably
we
our
could.
audience has had enough for.
So is there anything else you'd want to tell a parent? So speaking directly to a parent right now, is there anything that I didn't ask you that I should have, or that our parents should know that would make them feel comfortable about just beginning the process? They can always come see you for a complimentary consultation, right? Just to get the information.
They can, and I don't want to mislead anyone. It's not complimentary. There is a charge for the exam. It's an hour exam.
Oh, there is. I'm sorry. Okay.
Where we, it's about a half hour of examining and then a half hour showing pictures and trying to explain some of these things that we talked about,
Okay.
because it's new information to most parents. But if they end up seeking treatment, that charge that they paid is
Goes
put
towards
towards the treatment.
The treatment plan. Okay. Sorry, I misspoke there.
Yeah.
So what's the best way to contact you? Should someone want to contact your office just by phone? Is the email? Do you have a certain line?
You know, Google is the king to everything these days.
Okay.
You can Google O'Rourke and Wonderly Dental and get a phone number, and certainly by phone is the best way to establish an appointment.
And you have Dr. Wonderly there as well. Does she do this work as well, or it's only you that does this work?
Dr. Wonderly does the majority of the frenectomies. She's taken specialized training in that, and we've invested in a new laser, which makes the treatment go very smoothly. There's almost no bleeding, and it's rapid and comfortable. So Dr. Wonderly does a majority of the frenectomies. I do a majority of the growth guidance, but Dr. Wonderly is taking some training on this. So
She is.
people that come in the future may see us working together on some of this treatment.
Fantastic. Okay. So now, is there anything I forgot? Anything you can think of you'd like to add?
No, I don't. I would only add that as a parent, if you feel something is wrong, follow your gut. I had a mom whose her husband's father was a dentist, and he said, you know, don't worry about this 5-year-old. She talked to her chiropractor, and he knew right away that things weren't going in the direction they should. And, you know, happily for her, I had treated his daughter, and he sent her my way. But there will be people that tell you this is normal development, but if your gut tells you it's not, keep digging.
Right. Yeah. I think
Excellent.
we tell people that all the time. We like it. Keep advocating, keep asking the questions, keep moving to the next provider till you feel good and feel like you have some answers. So great. Anything you can think of, Taylor?
No, I can't. Thank you so much for
Karen,
sharing
thanks.
your time and expertise.
From a sunny place, you came to this cold place, took some time to talk to us. We're so happy.
Oh, I'm thrilled that you asked me.
Oh,
I could
thanks.
talk for hours.
Oh, I'm sure we could.
could.
When we get back, let's have some lunch and let's catch up. We definitely need to do that. We talked about
Okay.
a webinar we needed to watch together.
Yes.
Yes.
All kinds of good stuff. Okay, well, enjoy your vacation, Karen. Thank you so much.
Thank you.
Take
Bye-bye.
care.
Bye-bye.
Bye-bye.